Welcome, everybody, and thank you for joining us for the Clinical Case Review live stream event today. The Clinical Case Review is a monthly live stream program that takes place on the second Wednesday of the month at noon. This series provides a review of clinical cases followed by a discussion. Please enter your question for our speaker in the Q&A box at the bottom of your screen. We will discuss questions at the conclusion of the presentation. To introduce our speaker today, Elizabeth Archer-Nandez. She is the founding member, clinical and operational leader for Norton Cancer Institute Behavioral Oncology Program. She earned her psychiatric clinical nurse specialist through the University of California, San Francisco, and her doctorate in nursing practice from Bellarmine University. Elizabeth is the current president of the American Psychosocial Oncology Society and is an advocate for the inclusion of mental health care across medical settings. Elizabeth is certainly a great advocate for all things mental health. I've worked with her on a number of committees, and really her work ethic and connectivity to all things and ability to help me solve problems is phenomenal. So I'd like to say that Elizabeth is not only a great colleague, but someone I consider a good friend. So with that, go ahead, Elizabeth.
Thanks, Jim. Let me share my screen here and get my slideshow rolling. And I think we're good. I'm really excited to be here. As Jim mentioned, I've worked in psychiatric oncology for my career here at Norton Healthcare, and I'm really proud to lead a wonderful team of mental health providers who deliver care to our oncology patients and collaborate across our primary care spaces and our oncology spaces to make sure that everybody across our multidisciplinary teams can be able to support patients as they go through this, what can be oftentimes a really challenging experience of having a cancer diagnosis. Okay. I do work as part of the BGene Mental Health Advisory Panel and don't have any real relevant financial risk associated with that. Just a great opportunity to talk about more broadly across the country, how do we continue to advocate for and include psychiatric care in the oncology space. So my hope today for our presentation is that we will talk through why we want to include psychiatric care in oncology programs. We want to look at recognizing normal emotions in response to stressors, and then describing out supportive care approaches for individuals with cancer illness, including those experiencing adjustment reactions and normal emotion in the context of a stressful life event, and then identify possible treatment approaches for individuals with psychiatric oncology concerns, including depression, anxiety, and delirium. So, I think it goes without saying that cancer incidence continue to rise. We're looking at there being 14.1 million cancer diagnoses in 2012, all the way up to 21.6 million in 2030. And that's partially through earlier diagnosis. And then with that comes that we're going to have more cancer survivors worldwide. So looking at there being, over 300 worldwide cancer survivors. Death from cancers are also going to rise from 8.8 million in 2015 to 12 million in 2030. So there are, as you can imagine, a host of psychiatric and emotional and psychological complexities that can arise in the context of grief, loss, adjustment to illness, loss of work, changes to our body functioning, and different things. So cancer is a series of different complex illnesses, often chronic in nature, requiring multidisciplinary treatment and attention to help us understanding the psychosocial aspects of care, interpersonal aspects of care, emotional, physical, and spiritual needs. So cancer patients, what we know is that cancer patients have higher levels of psychological disorders than the general population, and cultural and personal backgrounds contribute to how individuals will present with psychosocial distress. Stigmatization of mental health concerns can contribute to patients presenting with a very stoic approach and maybe minimizing any mental health sequela that they may be experiencing, or potential contribution to a higher level of somatic presentation, complicating medical teams' ability to really get to the core of the symptom that needs to be treated. So it's really important to look at, I switched my note pages and my presenter screen, so I'm just trying to shift some things around here a little bit. Okay, so it's important for us to talk about equity and inclusion. Underserved populations are not only at higher risk for cancer burden and more challenges to quality of life, there's also complexities arising from higher symptom burden and distress, sometimes confounded by biological and genetic factors, often confounded by insurance disparities, other environmental factors, socioeconomic factors, potentially even limiting patients to being able to afford medications, further contributing to adherence challenges. And then that all, you can imagine, kind of culminates into higher levels of psychological concern and more distress. It's important for us to have all of the following. So cultural competency, so understanding knowledge and behaviors, attitudes and values that affect people across clinically diverse populations. Cultural humility, so this idea of understanding what our own awareness and critiques are, understanding our own biases and embracing different patients in that way. And then also looking at cultural empathy, so appreciation and understanding, as well as compassion for experiences across different cultures. So I think we all have probably had studies on social determinants of health. So looking at what are the things that impact outcomes. So educational attainment, employment and socioeconomic attainment and opportunity, housing factors, the neighborhood that we live in, actually can correlate many times to higher incidence of disease, just by nature of not having access to screenings and different things, food insecurities, social support challenges, and even just where a patient can prioritize health seeking and health behaviors into their hierarchy of capacity can be different across different groups. So looking at what a psychological aspects and needs are, it's really important for us as providers and clinicians to look at better understanding how patients may understand their illness, the treatments, and the services. Oftentimes we use complex terminology that's difficult to understand, and there can be a level of embarrassment and shame that can arise from asking clarifying questions. Better being able to interact with the treatment team and even being able to come to conclusion of what's been said out loud to them and what action steps they need to take to be able to mitigate their illness and adhere to the treatment demands. So if we think about the different tasks that patients are, facing, they not only have to adapt to understanding what this new illness is and what the treatments are that they have to undergo, but they have to cope with the emotions surrounding the illness and treatment, managing losses of health and functioning, often contributing to role strain and different disruptions across the family, including vocational disruptions, educational disruptions, changes to family and friend relationships, and then all of the additional financial burden that we know comes with the onset of a cancer diagnosis. So patients adopt a lot of different emotional, cognitive, and behavioral responses to the disease, and us understanding if our patients are coming from a place of fighting spirit, so like I'm going to get in there and overcome this despite the adversity of it, or a tendency toward a more anxious preoccupation and kind of really trying to figure out, what this illness will mean for them, how they're going to cope with it, how they're going to function. And then even those of our patient population who we know to be a little bit more denying of illness and reality, we have to really be able to approach each of those different groups of people in very different ways to meet their illness needs and help inspire their treatment adherence. So in 2007, the Institute of Medicine released a report, Cancer Care for the Whole Patient. Since that time, standards continue to be introduced, continuing to up the level of how we serve patients from an emotional, psychological perspective through their care journey. After that was introduced in 2009, the Quality Oncology Practice Initiative, or COPI, looked at the inclusion of making sure that we were assessing for distress in cancer patient settings as a part of our quality initiatives. And then in 2012, the American College of Surgeons, where the majority of cancer programs receive their accreditation, said that we think that this is a basic standard of cancer care, and we're going to implement this into what we recommend all cancer patients receive. So you'll see on the screen here, the NCCN guideline for distress is included. This is the most up-to-date version released in January of 2022. And it looks at patients experience distress along a continuum, sort of how we would measure and identify pain. So a patient may experience no distress all the way up to extreme distress. And what we know is patients experience their distress across different symptom domains. So it could be physical in nature, maybe relating to pain or sexual health challenges in eating, loss of appetite, emotional, looking at worry or grief, fear, loneliness, anger, social concerns, so relational difficulties and those role strains that I talked about in the previous slide, looking at challenges with interacting with partners, family, friends, coworkers, practical concerns. So I can't take care of myself. I'm having trouble with transportation, childcare issues, food insecurity, access to medications, or even complexities of, I don't really have a person I can rely on to help me make these complex treatment decisions. So how can we match the problems that they're experiencing with a source of support, either through access to a mental health professional, social work to help with navigational concerns, or therapeutic intervention, or even chaplains across our multidisciplinary realm to help with spiritual concerns, existential crises, death and dying, and from a practical perspective, even completion of living wills and advanced healthcare directives. I do want to speak a little bit about a broad range of normal emotions. So this is Mark Brackett's work. He's from the Yale Center for Emotional Intelligence. I had the pleasure of hearing him speak earlier this fall. He is a witty and wickedly funny man and incredibly smart. So he looks at mood across this mood meter, and all of these different emotions are normal. Mark's work is permission to feel. So we all experience fulfillment, elation and enragement. I hope enragement's a little bit less for some of us, feeling down or bored, tired. All of those emotions are normal and they're transient in nature. So I think what's important for us to manage and support patients through is that they're going to have emotional reactions to illness, just like they would any other life stressor. Emotions can be high in pleasantness, low in pleasantness, and high in energy and low in energy. What I think is important for us to understand as clinicians is this an emotional experience that someone is experiencing that's transient in nature, or what we'll talk about the remainder of this presentation are things that are more consistent, enduring responses that are associatable with a psychiatric diagnosis, either arising from the experience of cancer or exacerbated by cancer. So again, cancer patients are going to adopt a broad range of different responses to illness. And we talked a little bit earlier about hopeless spirit, fighting spirit, hopelessness, anxious preoccupation, and denial. It's really important for us to understand if patients have experienced any previous psychiatric concerns, Is there any trauma history? How do we engage patients to really use trauma-informed approaches to care and understanding if there were any adverse childhood experiences that may be contributing to really significant exacerbated anxiety or feelings of helplessness as they go through cancer, which is an additional situation of intermittent feelings of helplessness that can be re-triggering from past traumas. So cancers that may cause an increased incidence of psychiatric disorders include pancreatic cancer, oropharyngeal cancers, lung cancer, breast cancer, colon, gynecologic, and gastric. And common psychiatric diagnoses that we will see across cancer patient populations include adjustment reactions, anxiety disorders, depressive disorders, both major depression and minor depression. My picture got in the way of part of my words there. Other concerns that are beyond the scope of our talk today also include post-traumatic stress, sexual health disorders. My colleague and collaborator, Dr. Layla Agarwal, leads our sexual health clinic here at Norton Cancer Institute. Mood disorders, sleep disorders, and difficulty with demoralization. Whoop. So challenges exist in the context of adequate assessment and accurate assessment of psychiatric and psychosocial concerns in cancer. One of the major challenges is the overlay of somatic symptoms that arise both in the context of cancer recovery and cancer treatment and also psychiatric illness. So that somatic overlay might include appetite loss, weight loss, insomnia, fatigue, loss of energy, diminished ability to think or concentrate, and lethargy. And then the psychological manifestations can occur in both cancer and psych disorders too. So sadness, irritability, discouragement, libido challenges, preoccupation difficulties, memory difficulties or changes. I think we often will hear patients talk about chemo brain and difficulty with decreases in concentration. And so one of the things that we're tasked with as professionals is how do we delineate out that somatic and psychological overlay and confounding experience, and really tease out what is true depression, anxiety, and psychiatric sequela versus what is just like a brief emotional response to the illness. So we'll get into some of our diagnoses here. So it is important to collaborate across domains. I talked a little bit earlier about the team that I work with, and I'm so grateful to be part of. It is very common for us as members of our psychiatric care program to collaborate with our oncology team, the nursing staff on the units, the nursing staff here in our cancer program, and then also primary care. Sometimes once patients have gotten all the way through their treatment and they're doing really well on their psychiatric medication regimen, for instance, we might work with primary care to continue those medications. It's really important for us to highlight that patients often come to oncology with a really good rapport with their primary care provider, which has helped them get in for a timely diagnosis. And they rely on that continuation of that health maintenance and treatment relationship to continue to give guardrails to what they need to do across their journey, even though they're partnering more closely with the oncologist who's oversighting their anti-cancer regimens. So that can help with trust in the cancer team, and then help highlight the need for multidisciplinary collaboration. So as I mentioned here, we are really, really fortunate at our institution that we have a fully integrated and embedded psychiatric program. We're available within our institution to serve patients who are receiving treatment by the oncology providers at our cancer institute. We do partner to provide lists of community resources for individuals who are maybe treated beyond our network. And the reason this collaboration is so important is that we're embedded right in the same space with the oncologist to be able to provide that level of service within the same cancer setting. So I often will lead with this, that it's common error among the well to think that with a little more self-control, the sick might, if they choose, dismiss painful thoughts which aggravate their disease. Almost any sick person who behaves decently well exercises more self-control every moment of his day than you'll ever know until you're sick yourself. If he can speak without being savage and look without being unpleasant, he is exercising self-control. I think for us, illness is so normal, we forget that this is very not normal for the person who's going through it. And oftentimes, this is a patient's or family's first interaction with the healthcare system, which can be quite terrifying. So, adjustment reactions. Miss T was a kindergarten teacher. She taught for many years prior to the onset of her breast cancer. Medical factors necessitated a leave of absence from school. She became isolated from her peers, her friend group, and she found it difficult to create routines to meet her treatment demands. She began to develop interpersonal tensions with her partner and her son. So an adjustment reaction is a short-term but significant response to a life stressor, in this instance, cancer. It can contribute to short-term anxious and depressive symptoms that can interfere with functioning. Generally, the onset of an adjustment reaction is within 3 months of the identified stressor. About 20% of individuals with cancer will experience difficulty with adjustment. The important piece to look out for is that can impact the course of treatment among medically ill, and it can look like depression, anxiety, or mixed anxiety depression. Some interventions or adjustment challenges include group counseling, seeking social support, interpersonal stressor conflict resolution, which could be as simplistic as re-encouraging that fluidity of conversation between a patient and their family, their support team, even their medical teams. We can often use mindfulness-based relaxation therapies. CBT can be helpful and brief, and then reassurance and consistent visits with medical teams. So really reaching out and making sure they're adhering to coming into those appointments. Generally, this patient population would not need medications. So here is our first poll, and I think McKenna's got it built in here. What treatment would you recommend for this patient? Brief trial on an antidepressant, group therapy, individual therapy, or BNC, group and individual therapy. And McKenna, whenever you think there's enough answers in. Yeah, exactly. All 3 participants who answered it got it right. Great news. So Ms. T sought counseling with CBT and supportive therapy with behavioral oncology. She was able to identify stress that was contributing. She acknowledged she was having difficulty being honest with her family and friends, what she needed from them. And she began to open up more to her friends and family about her fears, joined a support group through Gilda's Club or the cancer support community, and opened up lines of communication and continued on through her medical treatment without significant difficulty. So Joe is a 54-year-old man without any pre-existing psychiatric history. He had been a high-performing executive with pre-existing anxiety. He worked through treatment for prostate cancer with intermittent worsening of anxious symptoms, including fear related to his ability to provide for his family. The intensity of his anxiety was really persistent in nature, and it contributed to treatment avoidance and significant difficulty with his family. He had difficulty with occasional panic, palpitations, diaphoresis, nausea, and dizziness. He was really hard on himself and used a lot of negative self-talk on top of having the cancer, that he was now also going crazy. So chronic anxiety can arise after the onset of cancer and also can be exacerbated by cancer. Common anxiety illnesses that we'll see across the cancer domain include unspecified anxiety, anxiety with panic, post-traumatic stress disorder. Approximately 23 to 44% of cancer patients will experience some anxiety. It's longer and more intense than an adjustment reaction. It may have some anxiety history or trauma history associated. and functional limitations or challenges to functioning, as well as reduced social support, can contribute to the development of anxiety. I talked a little bit earlier about the somatic overlay that is challenging. So some of the somatic symptoms that may present through primary care include fatigue, headaches, abdominal pain, sleep complaints, dizziness, paresthesias, syncope, weakness, and generalized pain. It is really important to do a detailed history and medical workout to rule out any physical causes, and thoughtful exploration of depressive and anxious symptoms could lead to better understanding of the somatic symptom burden. We use the Generalized Anxiety Disorder 7-item questionnaire in the behavioral oncology program here. And recently, my colleague, Dr. Reichert, completed study looking at the importance of screening patients for anxiety and the opportunity to expand fuller range screening across multiple settings so that we can really understand the depth of anxiety that patients are experiencing. One question that you could ask that could be helpful is, do you find yourself worrying excessively about minor matters? Looking into any additional difficulty with insomnia and depressed mood can help to further ascertain the experience of anxiety. So we have pharmacological and non-pharmacological interventions that can help with anxiety. Positive event scheduling, deep breathing, grounding techniques, promotion of social support, positive imagery, and distraction are all really helpful non-pharmacological interventions. Pharmacological interventions, if warranted, include SSRIs such as citalopram or escitalopram or sertraline, SNRIs such as duloxetine or venlafaxine, buspirone are all really good first-line interventions for a patient requiring medications for the experience of anxiety. Benzodiazepines are a treatment choice that is reasonable. It is important to limit use of benzodiazepines to less than 2 weeks with a full risk assessment completed prior to prescribing benzodiazepines. So any patient who has any substance use history in the past, receiving co-prescribed opioids, or a person with significant psychiatric history, it would be really important to limit or avoid use of benzodiazepines. Okay, so what would you recommend for this patient? Would you want to do pharmacotherapy alone, psychotherapy alone, psychotherapy and pharmacotherapy, or nothing? He will probably be okay. Okay. Yep. Pharmacotherapy and psychotherapy together is what I recommended for this patient as well. So Joe committed a routine therapy with consistent adherence to psychiatric visits. He had improved adherence with oncology treatment demands, oncology follow-up. We initially did some non-medication based strategies, including event scheduling, increasing time with social supports. He was able to work through some of the fear-based anxieties, and really evolved to the idea that he would benefit from the addition of an SNRI. He's currently in cancer survivorship without evidence of disease. He looks forward to time with friends and family, and he actually successfully transitioned oversight of his psychotropic medication to primary care, who is helping to oversight and manage these medications now. I do see questions popping up, so I will keep going through the case studies and we'll get to those questions. Thank you all for being engaged and asking questions. So we will move on to Dot. She is a 59-year-old woman receiving care for malignant lymphoma. Treatment has required frequent hospitalizations, which initially contributed challenges with social isolation. She had initially been admitted to the hospital during the pandemic, and so she really hadn't been able to have many visitors up. As she hasn't required as many inpatient admissions, though, Dot continued to be isolative and withdrawn. She really admitted to not looking forward to enjoying events. She was having difficulty with low motivation. Her sleep is disrupted, and she does experience hypersomnia and low energy. She reports feeling as though she's a burden. She's let her family down. She has a lot of guilt related to her illness, despite attempts to provide education to her that her illness isn't her fault. The patient has passive thoughts of death without a plan for self-harm or a plan to do anything to hurt herself. So depressive disorders could be new onset, chronic, or recurrent in nature. Symptoms generally exist for a period of 2 weeks or more and may include depressed mood, social isolation, difficulty with being withdrawn from usual activities, sleep instability, so either too little sleep or too much sleep, feelings of low esteem, guilt, or hopelessness. So she, again, had a lot of significant overlap between somatic symptoms and the experience of her depressive symptoms, including hypersomnia. She was not eating well, and she was really being isolative. So one of the things that can be helpful is to delineate the patient's ability for enjoyment and engagement with social supports as one of those key features to diagnosing depression in this patient population. Untreated, the patients are at high risk for continued difficulty adhering to treatment regimens, low quality of life, and poor outcomes. So in our group, we use the PHQ-9. It's a scale that's widely used with high validity and reliability. It assists us with understanding symptom severity, diagnostic concerns, as well as helps us to track over time if the interventions that we're doing are helping the patient to get better and have symptom improvement. We conducted a study here in the office in 2013 and looked at non-pharmacological interventions combined with pharmacological interventions, trying to determine if those combined modality interventions showed improvement. And as you can see, there was significant improvement across the 41 participants in the different domains, including depressed mood, difficulties with sleep, feeling as though they were a failure, psychomotor agitation, and overall distress. All the PHQ-9 questions did show some improvement, with just those highlighted showing statistically significant improvement. So, okay, which intervention is most appropriate? Psychotherapy alone, pharmacotherapy alone, psychotherapy and pharmacotherapy, or nothing, she will be fine when her cancer goes away. I'm really hoping no one answers D. Okay, let's see what came in. Okay, no one answered D. You could absolutely do psychotherapy alone with this patient. I think the challenge was that she was continuing to show significant difficulty engaging in activities and participating. And so the addition of that medication is really helpful for being able to kind of reboot and offset some of the level of the depressive illness. Okay, Doc, she was really reluctant to seek care with behavioral oncology. I think her husband nagged her until she finally relented to come and establish care. She was able to formulate some understanding of how much grief she was experiencing. The nature of her illness did not allow her to continue on with work. She had changes in her interpersonal relationships based on pandemic limitations for people to be able to come into the hospital. She experienced role changes at home. She eventually began to trust and open up with her support system. She became very engaged in therapy with behavioral oncology. And, you know, eventually she was able to see that she wasn't a burden on her friends and family. She was showing good, promising improvement from her cancer regimens. She did agree to use of antidepressant medications. She had actually been on an SNRI in the past. We added a NDRI, bupropion, to help with her energy and motivation. She did continue to struggle to make routine appointments with us, but we do continue to work on goals and address symptom opportunities. Okay, delirium. Rick is an 82-year-old man. He didn't have any previous cognitive concerns or psychiatric illness. He has no history of substance use concerns. He came into primary care after his daughter noticed that he was acting goofy and he didn't sound like himself on their more routine morning phone call. So delirium is an incredibly distressing event to patients and families. It is an acute neuropsychiatric disorder with the hallmark of waxing and waning mental status. So the patient could present with inattention, disorganized thoughts, or perceptual disturbances, maybe even hallucinations. I think it's really important to consider that delirium is incredibly distressing. It also can increase hospital length of stay, and it can increase the cost of patient care anywhere from $16,000 per patient up to $64,000 per delirious patient per year. It costs the healthcare system nationally somewhere between $38 billion and $152 billion annually. So delirium is probably not the thing that's going to present the most in primary care, but it certainly could. And is considered a psychiatric emergency, so really important to be aware of and know. As many as 90% of hospital patients will experience delirium across the illness trajectory, and it's often found, just like this woman and her dad, the person starts acting a little bit goofy, and if you don't catch the person right at the right time, they may seem very much like their normal self, again, because there's that waxing and waning mental status. Sometimes they're oriented, sometimes they aren't. It's important to treat the medical factors first, modify and simplify medications, adjust environments, so keeping it just like it should be outside at night. You want it dark in the room when it's nighttime, light in the room when it's daytime, sleeping at night, awake during the day. And then that frequent reorientation from family to help just reorient from a non-pharmacological perspective. Medications can be helpful when treating behavioral disturbances. Some of the etiology and risk factors for delirium include infections, dehydration, electrolyte disturbances, thiamine deficiencies, pain, paraneoplastic syndromes, intracranial cancers, seizures, long-term effects of brain radiation, opioid toxicities, corticosteroids, and cephalosporin antibiotics such as cefepime can actually present with complicated delirium. So again, delirium can be a subacute or an acute onset. I think it's really important to note that delirium onset is over a period of hours to days, which distinguishes it from depression. The onset of depression is over weeks, and cognitive decline or cognitive impairment onset, which we would see in dementia or Alzheimer's, that's going to be over months. So those are the important things in primary care to kind of delineate out. Again, it can be inattentive or disorganized perceptual disturbances like hallucinations. And generally the people's sleep cycle is going to be really off. Like the person's not sleeping at all, or they're never waking up. Not sleeping at all. And that's generally the patient that we're going to see that has significant irritability. Whereas a person with a more hypoactive delirium really could look like a person who's just a little bit tired or depressed. And those are a little bit easier to miss. One of the assessments that we'll use for delirium assessment is the confusion assessment method for the ICU, the CAM-ICU. Another one that we may use is the SLUMS, the St. Louis University Mental Status Examination. So again, I talked a little bit about the non-pharmacological interventions, including modifying the environment, reducing stimuli, having close friends and family present. It is important to note that if the patient is agitated by the presence of a specific person, removing that person from the equation rather than continuing to like argue out the rationale for having that person there can be really important. If they're in the inpatient setting, consistency of staff. If they're in the ambulatory setting and the delirium is being treated by primary care because of an infection, perhaps, it can be really important to make sure that that patient is monitored in the outpatient setting and not home alone. Clear communication, and then addressing medication side effects. The patient may be on a medication that has a lot of anticholinergic effects, and that could be contributing. Pharmacological interventions include typical antipsychotics and atypical for the behavioral disturbances. It is important to note that there is no FDA approved medication for the treatment of delirium. Rather, these are being used to treat the mood or behavioral disturbance. Okay, what should the PCP do to evaluate this patient? Send them for neuropsychological testing for a new dementia concern. B, complete the full medical workup and identify medical concerns, including risk for infection. C, refer to psychiatry to intervene with new goofy behaviors. D, add a medication for dementia and follow up in a month. Or E, brief psychotherapy. Okay, let's see. Yeah, complete full medical workup just to see what's happening. So Rick, his daughter came and got him, took him into the PCP for evaluation. He hadn't been eating well and was noted to have an acute UTI upon presentation. The daughter identified early that her dad was acting goofy, got him into primary care. Primary care listened and said, this doesn't sound right. He's also having some urinary retention. And then he followed up with PCP after completion of treatment for his UTI, and he's doing well without any ongoing cognitive burden or changes. Suicide assessment is really important as well. So suicide in 2020, there were 45,979 Americans who died by suicide, the 12th leading cause of death in the United States. And the suicide rate is 4.4 times higher in cancer patients. It is underreported and underestimated. It can be exacerbated by medical comorbidities, including hopelessness, feelings of demoralization, and individuals at particular risk are elderly, white, unmarried men, individuals with diagnoses of lung cancer, head and neck cancer, testicular cancer, and Hodgkin's lymphoma. Additional risk factors that are important to know about is if a person has had a previous suicide attempt or an expression of intent for self-harm, individuals who are highly socially isolated with other psychiatric comorbidities, and people with substance use concerns should be closely monitored. The PHQ-9 is the scale that we use for depression screening here in our ambulatory setting. It does, the 9th question is specific to, have you ever thought about suicide or thought you'd be better off dead? It's phrased something like that. The ASK suicide question screening questionnaire that I have pictured here is one that is recommended by the National Institute of Mental Health and frequently utilized. The Columbia Suicide Risk Assessment is what's used in our inpatient spaces here. And it's important to know that inquiry about suicide or thoughts or risk does not increase risk. It's important for us to understand history of family suicides, prior personal attempts, comorbid psychiatric disorders, including depression, use of substances that can be under or not reported, and then examining thoughts. So is there a plan or intent? And if there is a plan or intent, ensuring safety measures. So looking at, do we need to be removing firearms from the home? Is there someone that could lock those up? Has a person been stockpiling medications with their plan to utilize or take their medications? So care includes education and support to these patients. You want to consult with psychiatry. If a patient is in the ambulatory setting, we can do safety or wellness checks to have an officer go out and check on that patient if we receive a call or a message from a patient and they're not in our space. We can provide them with the suicide crisis hotlines, including the new 988 model, improve access to mental and psychological interventions, and then psychotherapy and pharmacological treatments can be important. If a patient is actively suicidal in your office, getting them safely transported to emergency rooms is the standard of care, so that we can do that next level of screening and identify if a patient would benefit from or meet criteria for an inpatient hospitalization. So it's important to help patients to understand that normal emotions are going to arise in the context of a stressful life event, especially a stressful event such as cancer. For persistent emotional concerns, normalizing the connection to a mental health provider or connection to a community support group is really important and can be quite powerful. And then team-based collaborative care, including primary care, oncology, and specialized psychiatric providers, really are the gold standard for making sure we're meeting whole care patient needs. So I have some references there, and then I will take questions, including looking at the ones that I have up here on the screen. So how often do we see mental health issues that arise years after initial treatment that may be related to ongoing treatment, specifically hormonal therapy with breast cancer survivors, and how do you help patients through that? We will see patients who have survivorship issues that could be related to hormonal therapies. We would do a standard psychiatric assessment and then determine if care through our program, or if there's, a long-term historical challenge related to a more chronic mental health concern exists, and try to connect that person to appropriate resources. It may be a combination of psychotherapy and medication management, and sometimes it means looking at what endocrine-based therapy the patient's receiving to see if that could actually be contributing to the mood changes as well. So if that's the case, then working with the patient's oncologist to say, the onset really did seem to co-occur with the start of this new medication. Is there something different that we could try to help keep their breast cancer recurrence risk as low as possible, and also easing their mood burden? So
Elizabeth, I have a couple questions that I wrote down. So do you have any estimate that comes from literature or even anecdotally in your own experience of how many people come into their cancer care with a behavioral health diagnosis versus how many people actually develop one because of that diagnosis?
Yeah, I don't know that I have specific on how many come in with pre-existing and then either worsening or additional after diagnosis. What we do know is that the literature is really broad on what the incidence of co-occurring psychiatric illnesses and cancer. Some studies suggest that it's all the way up to 60% of patients will experience some co-occurring psychiatric concern.
Okay. And then when you were listing the most common cancer diagnoses that have some sort of behavioral health issue that go along with them, I was actually rather surprised to not see prostate cancer on there. And largely because of the treatment that's required, and men tend to always consider themselves both invincible and strong, and to have to admit that they're neither invincible nor are they strong enough to just beat cancer by flexing their muscles. Yeah. I think is a huge ego blow.
Yeah. My colleague, Dr. Roth up at Memorial Sloan, would suggest that prostate cancer does actually have a fairly high incidence of co-occurring depression and anxiety. I think one of the challenges is women often more readily seek psychiatric services, And so I think this is a example of something being underreported rather than not existing.
And that was one of my suppositions on it, but
Yeah.
I figured you would have better insight into that.
Yeah.
So I don't see any other open questions, and those were the two that I came up with throughout your talk. I thoroughly enjoyed it. I think you did a great job, and I feel like our audience certainly got a better understanding of not only the comorbidity of cancer diagnosis and treatment with mental health disorders, and the effectiveness of treating them, whether they came purely as a result of the cancer diagnosis and the resulting grief and adjustment and everything else that goes along with that, or whether they were something that was already there at a low level and then having this life event alter them. So I very much appreciate it. Unless there are further questions, and I don't see any others, then I'll just say that this concludes our program today. If you're registered, you will receive a link for an evaluation for credit. You can scan the QR code that will be displayed on your screen shortly. Please join us for our next clinical case review live stream on Wednesday, January 11th at noon. Joshua Hayden will discuss the utilization and interpretation of urine screenings. So I appreciate everybody's time and attention, and I hope you have a good rest of your week.
Thank you, everyone.